the more confidence you will have in what you're going to do. So if you have the top row plus adjunctive evidence, you have a heck of a lot of evidence that there is something horrible going on that maybe the medicines are not going to treat. But if you see somebody with LA grade B on BID PPI, clearly that person has refractory reflux that we are not going to be able to solve with medicines. I think in that situation, your B will give you your answer. But I don't think we were never intended for this figure to tell you what to do. This figure only tells you how much confidence you have in reflux as a potential mechanism for symptoms.
I would push back a little bit about the reflux being a purely symptom-based diagnosis. I think I prefer John's buckets. I think there are some people who clearly have organic disease in whom this is a major problem independent of the symptoms. I refer to the fact that a third of people with Barrett esophagus who get cancer don't have reflux symptoms. And I think those people clearly have significant disease even though their symptoms are not the major issue.
If I can, Renato, Salvador, I feel like one of my favorite movies was Independence Day. You know, until 10 years ago, I think all the gastroenterologists tell you don't need surgery because it doesn't work for reflux. So, and now in one afternoon we say, okay, we are moving to. We can have an indication for surgery, anti-reflux procedure, wherever, from the esophagitis grade B. Speckler 2 years ago tell us with the refractory Harbor, probably you can have a better outcome with surgery. So I don't know, is something coming like the spaceship is coming to the hand of the surgeon, and in 10 years we will see the outcome going down because we are taking operating room all the wrong person. So I don't know what's going on, but probably I really enjoyed the session anyways. It was just a comment from the surgical point of view. And also I never imagined to be the lawyer of the GI with John, because I cannot believe we don't need a classification. Of course we need, because we cannot take in operating room everybody to do links or wherever was stuff. So really, I enjoyed the session.
So the thing is, gastroenterologists are drinking the same beer as John. So I think we're moving to the middle, and so are our surgical colleagues. They're identifying the people they shouldn't operate. So, you know, we are giving you bucket 3, and we are reluctantly accepting bucket 1 from you. We don't like those patients either.
You know, Prakash, few questions. Number one is that I have one problem with Lyon. There is absolutely no clinical questions a part of it. You know, classical heartburn, response to PPI, you find a 4 or 5 centimeter hiatal hernia. Why do you need to have any of these criteria to make a diagnosis? And 2, let us say you say by a modern diagnosis, the patient doesn't have reflux. That's a bottom 1. And if he says he's very happy with PPIs, what do you do?
Again, the Lyon consensus is not telling you how to treat your patient. Where you need to go is...
Diagnosis should direct treatment.
Not necessarily. Personalized management is the way to go. So you cannot create criteria for personalized management of a figure like this. You have to help the masses. And this is a guide. You know, yes, of course, there are patients with large hernias who are a completely different phenotype that may not necessarily fit here. But as a surgeon and as a gastroenterologist, we have to be able to recognize those people who don't fit. Guidelines are guardrails that tell you where most of the patients will lie, with the understanding that, yes, people will lie outside those guardrails, and we have to be able to recognize them. And the best way you can do that, more data, and talk to the patient. That's what I try to do.
One more thing, I would push back against that regurgitation versus a rumination. That was, you know, most patients regurgitate after meals. So how do you distinguish between a rumination versus a regurgitation?
By the number of events per 30 minutes.
He's more miserable.
It is measurable. It's measurable with
No, he's miserable. That's why he has so many reflux events.
Well, we can measure it, and also by the, as I said, these are symptomatic events. Most of reflux patients don't push the event marker every time that they have a reflux episode. we compared the patients that had a positive diagnosis of rumination based on HRM with impedance and this MII recording versus patients without positive diagnosis of rumination with HRM impedance. And the difference between the patterns is very important. The number of events is much larger, and particularly these are symptomatic events. So the pattern can distinguish ruminators from just pure reflux disease regurgitators based on numbers.
Well, I'm just going to assume in that link study, if they were going mainly by the number of regurgitation, so-called episodes, and pH, they must have had some ruminators because clearly the surgeons are not that smart to distinguish between them. But the patients did very well. So I'm just trying to figure out that are they a very small number and we don't need to, how do we find those? Or is that they do great?
I will answer something that you will not like, but I believe that surgical procedures have an enormous placebo effect, and particularly important in patients with psychological comorbidity like those with rumination. So I'm not surprised that a patient with rumination does well with a surgical procedure. I'm not surprised.
And if he does well, why are you arguing against him doing well?
Because there are less invasive treatments with less risk and almost for free.
Well, a psychiatrist's visits will be probably a lot more expensive than John's links, and that's expensive treatment. So I'm just, if the patient has a disease, he fixed it, they're doing good.
But the average number of reflux events in the specular study, regurgitation events, was somewhere between 7 and 15. We're talking about people who have 50 and 100 reflux events. If you see that, 50 events, and it's a symptom index of 100%, I promise you, you want to think twice.
Yeah.
But I have...
Never see those patients.
there you go. You screened them out.
Yes, yeah, yeah.
They never see them.
See, for the Caliber study, the randomized study, Marcelo and I screened every single pH impedance study, and we pulled those people out when we identified those people as ruminators. For the on PPI study, we did consensus evaluation. We pulled people out who were ruminators and supragastric belches. So the people who underwent surgery on that BID PPI group, they were not ruminators because those were excluded, even if they had surgery.
So you're being protected from these people.
So I have a question. I mean,
So this guy, I'm so sorry, I forgot. Daniel, sorry. Has been waiting a long time. Just let Daniel step in.
Two comments about the definition of a disease. It's always the first approach using epidemiological data, but it helps you to discriminate between normal and abnormal. But when you're in front of a patient, you know that he's not normal. You're trying to classify him into distinct diseases or trying to predict which treatment is going to go better, but you know that he's not normal. Two examples for that. If we use epidemiological definition for obesity, at least in the US, the body mass index probably would be 22, 23, I don't know the exact number, but we know the risks start even below that. And second, that is a personal anecdote, and I always use this to clarify this. My head diameter, a neurologist friend of mine measured it, it's beyond percentile 95, and I'm still here listening to all of you. So epidemiological definition is just the best, the first thing that you do, but it's not the best. Correlation with outcomes is significantly better, is what the patient is expecting from you.
Thank you. Sorry, Ronnie.
no, I think the big elephant in the room when it comes to Lyon, and I wanted to hear from both of you, is really the patients that end up in limbo, because we really would like to know either you have it or you don't. So when you have patients that end up with borderline or inconclusive evidence, and I know we can go through some adjunctive, I mean, one of the concerns that came up and I heard as comments about the Lyon is what do you do with these patients and what's going to be the outcome? And for example, I would like also to hear from the surgeons. What happens if you get a patient that comes from the group of borderline or inconclusive GERD? Would you be performing surgery or links on these patients? Maybe John.
Well, I mean, to me, that's clearly the middle bucket. That's, you don't know if it's beer or wine cooler, and you don't want to make that mistake. So those are the patients that I think we as a group need to work on to identify who's going to do well and who's not. So if you send me a middle bucket patient without anything else, no, I don't want to operate on them, because the outcome, if it's a wine cooler, is going to be similar to that functional hypersensitive patient, and it's not going to be good. I've got hundreds of those albatrosses around my neck that I made that mistake. So it needs further investigation, and that's, again, where I think we as a group can help determine that.
And now I have to say that between Lyon 1 and now, we have made some progress in trying to reduce that group, in trying to be more specific about who needs to be in that group. And wireless pH monitoring over 4 days has helped with that, because that 4 to 6% range, if you have a dominant pattern, they're going to move to the conclusive reflux. And some of those are going to move out of that category. And LA grade B is the same element. So again, we're trying to become more specific, and we are not. You may have to repeat the test on PPI and see what you find. So I think we are making some moves. Obviously, a lot more needs to be done.
We have a question here.
No, just a commentary, because it's important to differentiate rumination versus regurgitation, and it's easier with, like Daniel says, because rumination doesn't appear with reflux. It's important to remark that patients with rumination never present acid. Inclusive stop to ruminate when she or he or patient feel the acid exposure in their mouth. And inclusive in pH monitor, we can see and differentiate rumination versus regurgitation for that reason. The rumination almost never have acid exposure, I think. It's important.
So unfortunately, there's a lot of data saying that there's not such a clear cutoff, but if you see what you described, then that's clearly one that we're going to take away before the surgeons get referred. Mario.
Yes, from a surgical point of view, I'm talking about the limbo patients. You know, I can't say never, but I will not operate them. I will have an option of wait and see, to discuss with the gastroenterologist and to perform maybe in 6 months' time another test and so on. The problem is that this is not the real world. We are a group of very dedicated people here, both gastroenterologists and surgeons, and we can speak to each other. The problem is that the countryside is completely different, and the country gastroenterologist is fed up of this patient, and they send them to the surgeons. The surgeons don't understand anything about pathophysiology in the countryside, and they operated them because it's a fundoplication, is a quick operation without any great risk. So this is the real problem in this limbo patient. And then they came back. They come back to you, and they have to fix the problem. So to answer the question from a surgical point of view, a dedicated surgeons, a wait-and-see technique or approach is the best of all. Thank you very much.
Well, okay, Rami, you get the last word before we move on to Prosecco.
Thanks. I like getting the last word. One of the ways that I find, Sumit, to differentiate between these and the limbo patients and all that, and one of the very simple ways to differentiate between rumination, supragastric belching, all these things, is what happens at night. Because these patients will not regurgitate at night. They won't belch at night. And if they have symptoms occurring at night or evidence of regurgitation at night, then you shift them into the bracket of the belching might be secondary as opposed to primary, for example. And I think that's very important. I always look at the nighttime. That's very important.
Well, everyone's nodding up here, so on this rare moment of consensus, let's bring this to a close.